Good afternoon, everybody. Oh, thank you. Who's that? Wow. What an incredible, incredible view here, seeing the entire audience. Every chair is full. So thank you so much for joining us here today. I think the mic needs to be a bit louder, but I'll try to project my voice. My name is Ike Ahmed. I am from Canada, United States. It's my extreme honor to chair this illustrious panel and to welcome you to our symposium from Medicontur. We have an illustrious panel of speakers here from Mexico all the way to Australia, and I think you're going to really be in for a treat. I've had an experience now working with Medicontur for the last year, and it's been a real enjoyable experience. I hope you'll enjoy hearing about the technology. You may see the theme today we have is on Beyond the Blur. And of course, when we think about Beyond the Blur, as cataract and IOL surgeons, our goal is to clarify and improve our patients' vision even beyond what perhaps natural vision may be. But also, the theme is also, how do we also clarify some of the misconceptions and some of the confusion out there in terms of how do technologies differ? And as we go through the speakers today, I'd like everyone to think about the goals of our surgeries and how does the technology, specifically lens technology and the optics and the advanced technology we put in patients' eyes translate into clinical outcomes. As I said, it's been a great honor to be here this morning and this afternoon, and I hope that we'll all be interactive. We do have an opportunity for Q&A and questions, so please send in your questions. You can take your phone, everyone take your phones out and scan that QR code. By the way, how's lunch? Pretty good? Okay. Yeah, we need some good energy here, okay? It's already middle of Saturday, ESCRS. It's a great time here in Barcelona. Well, I'm going to get the program started. I guess you're probably tired of me speaking now, so I would like to introduce a good friend of mine, Lupita from Mexico City. She's at APAC. You've seen her across the globe talking about IOL technology. I would say if I could describe Lupita, I would describe in one word, happy. And she's going to share with us how do we achieve the best outcomes to keep our patients happy with the goals we have in surgery. Thank you so much, Lupita, for being here. Thank you.
Hello, everybody. As I said, my name is Guadalupe Cervantes, and I come from Mexico City. I work in a huge hospital that is called APEC, Asociación to Prevent Blindness in Mexico. I'm going to tell you a little bit about how to keep a patient happy after you implant a trifocal lens. I don't have any financial interest. For me, there are 3 steps that are main steps. It's an excellent candidate. You have to look for it. It's not for everybody. Then you have to do a very good calculation of the intraocular lens, and then a perfect surgery to have good results. For me, this study makes almost my whole talk because it tells you all the reasons why a patient is not happy. What are the causes of dissatisfaction when you implant a multifocal lens? And as you could see, there are 6 special ones, and the main one is blurred vision. 64.5 are not happy because they have residual ametropia or astigmatism. Also, they have a posterior capsule opacification, large pupils, aberrations of the cornea, decentration, and of course, dry eye. But the important part of this is that if you as a surgeon identify these causes and you know it ahead of time, you can treat them before the surgery. Dry eye, we have talked about dry eye since I was a long, long time ago, but we never paid attention that now we have some basically scientific evidence that dry eye is very important. Why? Because we believe that dry eye makes the keratometries abnormal, but now there is a paper, a very interesting paper, that says that it also modifies the axial length. So if you can have a perfect lens, you cannot repeat the axial length if you don't have a good corneal surface. The second one is a very interesting patient because in this patient they have a 120 patients who show up just for cataract surgery without any dry eye symptoms. And when they did a questionnaire to them, a lot of them, almost 59% of them, have some symptoms. So it means that it's a high prevalence of dry eye, even if the patient doesn't know she has a dry eye. So it is mandatory to do a dry eye study before surgery. Talking about astigmatism, you know you have to correct it, otherwise it's going to be against your trifocal satisfaction. And as you can see in this study, the patients who had the less amount of astigmatism left were the happiest, and the ones who have more astigmatism were less happy. So if you don't correct astigmatism, you are going to be in trouble. This is a very nice study performed by Joaquín Fernández, where he did visual MTF, the focus curves, and contrast sensitivity, and where he discovered is that pupils who make better when you put a trifocal lens are those that are smaller, 2.5 to 3 millimeters in size. So please don't implant a lens if the pupil is higher than 4. Talking about some corneal aberration, just a little important part, the comma is the one that you have to look. Comma has to be smaller than 0.32. Talking about decentration, we did a study last year, and we took 3 platforms, as you can see. And one of the important things is that the central ring of the 3 are completely different sizes. So if you don't know that, you have to remember you are not supposed to exceed 0.5 millimeters from the central ring, otherwise your lens is going to be decentrated and patient is not going to be happy. Why? Because the contrast sensitivity is going to decrease and they are going to have halos and glare in more amount if they have a decenter intraocular lens. This is part of the study that we did, and we performed all this total area under the curve, and if you see it, the patients who were more happy were the ones who were rather center. Of course, the temporal center were less happy, but the worst one was the nasal ones, the nasal decentration. So decentration has a remarkable negative impact in the outcomes if you don't center the lens. And you should try to avoid to leave it nasally. My recommendation will leave to have the haptics vertically at 6 and 12. Talking about the numbers of rings, I don't think if everybody thinks about it. How many rings does the lens that I'm going to implant has? And the lenses have completely different amounts. You can see one has 7, the other one goes from 21 to 29 rings, and the other one has 15 rings. Do the rings really matter? That will be the question that you should ask yourself. And it matters because the more rings you have more light dispersion. Of course, the patient is going to have more diphoptosias and is going to be dissatisfied. So with this kind of platform, with 7 rings only, we will have a 20/20 happy patient. The high ABI number, I don't know if you look at the ABI number, but it's very important because it talks about light dispersion. And here's a table with different platforms with the ABI number. Usually they go from 30-something to 40, but if you look now at the lens we were talking about, the Medicontur lens, it has a very high ABI number. 58 is one of the highest ABI number in the market. So of course you will have an excellent contrast sensitivity under different illuminations. To finish my talk, I just want to remind you to have in mind the ocular comorbidities that the patients could have, like previous refractive surgery. If you have a radial keratotomy or high-order aberrations, please try not to implant a trifocal. Glaucoma with a severe damage of the visual fields, they are going to have less contrast sensitivity, and with if you implant a trifocal, they are not going to be happy. And at the end, you have to think about retina. Retina can have many diseases, and of course, they don't go along with a trifocal lens. So, thank you very much for your attention. Thank you, Ike.
Thanks so much, Lupita. That was a great introduction about our goals. We want to set the goals of our surgeries. I'm just curious, by a quick show of hands, informal poll, how many here routinely use some form of multifocal lens technology? Put up your hand. Okay, so I would probably say maybe a quarter. How many here in the room routinely use some form of extended depth of focus lens in practice? Okay, so I would probably say maybe almost about a half. Okay, great. So I wanted to just maybe open it up, and by the way, please make sure that you use the QR code to allow us to interact with you and ask questions. But I wanted to maybe, first of all, maybe focus on a couple of things. Now let me tell you something. There are a lot of technologies out there, and it's very confusing to me when you think about all these things here. By the way, now we have our chief guest, Joaquín, here, so how about a big show of hands? He already gave 10 talks today, so he's a busy guy. You know, and I think that for me, at least as a surgeon, I always like to understand the optics of the technology we place in our patients' eyes. The clinical data is obviously really instructive. I wanted to maybe open it up to the group here to maybe just talk a little bit about the Liberty lens. This is the lens, of course, that's a full range of focus lens. And in terms of what features are there for this technology that you believe are distinctive and unique when it comes to IOL technology? Anybody want to just start the chat about a bit about just specifically optic technology, multifocal goals?
Yeah, thanks, Ike. I think the most outstanding feature is the number of diffractive rings. It's direct correlation between the amount of dysphotopsia and the amount of rings you have. More interfaces you have, more refraction of the light happens, and you get more patient symptoms. So the Liberty lens has got just 7 diffractive rings, which is only within the central 3 mm of the optical zone. So it's a diffractive, refractive platform, and it was very good evidence. We have published almost 5-year data on this. This is the longest published data on any of the trifocals out in the market. And we show that the results are very consistent. We have done VFQ-25 questionnaires, which shows that the patient-reported outcomes are very less with symptoms of dysphotopsia as compared with other trifocal technology. And the other features which Lupita showed was it's got the lowest refractive index, which means the amount of glistenings are much less. It's got a very high Abbey number, which means the amount of chromatic aberrations are quite less as well. So those are the outstanding features for mine.
Well, I think, Sathish, you summarized it very well. You would get 100% in your Royal College exam, so thank you very much. And again, I encourage you to really kind of think about the differences in technology. And I do agree, this is in my experience, this is a very unique technology. I want to just ask someone to stand up here in the room. Laszlo Kontur, stand up for a second. Stand up in the room. Because Laszlo is a very unique man. If you visit the booth, please see him. His knowledge of optics is second to none. He's actually the owner and the founder of the company, but he's a very down-to-earth man. So please get a chance to talk to him. You'll really enjoy the experience. Well, I'm going to actually move the program along because we have a lot of things to talk about here. It's my pleasure to introduce Joaquín Fernández. I think we all know Joaquín as a council member of ESCRS. He's based out of southern Spain in Almira. He has recently led the effort to help us classify presbyopic lens technology. I think it's a very important area that as we go through all the different options that are available to us. I know you've been running from program to program, so thank you very much. You're not even breaking a sweat. I'm impressed. So thanks you so much for being here, Joaquín.
Okay, thank you very much for your kind presentation. I'm going to introduce you in my conflict of interest and my best friend. And my apologies for the time. So we would like to talk about the new formal functional classification. This is our disclosure. You have a relationship or consultant with Medicontur. Well, recently, this month in August, we published in Journal Cataract Refractive Surgery this functional classification evidence-based of all the simultaneous visual lens. Simultaneous visual lens are all the lenses that increase the depth of field, except the accommodative. And we are seeking for a global consensus to talk about apple with apple, orange with orange, instead of the mess of intraocular lens, intraocular simultaneous vision lens that you can see in the exhibitor room, at least to have a guide to classify that. Let's begin with Filomena. With this paper, we published a scoping review and a cluster analysis. The cluster analysis is a statistical method that used in machine learning to try to identify different subfamily of all the literature published in simultaneous vision lens in PubMed from 2010. So we discover different groups, two main groups. I'm going to tell you as simple as possible. The cutoff that we use is the 0.2 logMAR. 0.2 logMAR because the regulator ISO ANSI used to use. 0.2 logMAR, you can see here this cutoff, and we put also 0.3 because in the literature we use that historically as functional vision. So the distribution of light, the defocus curve below 0.3 is not going to be useful for your patient, you need to know. The cutoff of the 0.2 logMAR, if the lens achieves less in the defocus curve than 2.3 dioptries, we are going to talk about the partial range of field, not range of focus, it's an optical concept. Range of field is the clinical. If we are going to have in this cutoff of 0.2 more than 2.3, we are going to talk about full range of field. It's very easy to understand. 0.2 logMAR, and the cutoff is 2.3. What about this big group of partial? We're going to separate into three groups. In the cutoff point of 0.2 logMAR, it achieves at least 1.2 dioptries, less than 1.2. We are going to talk about then partial range of field, narrower. This is the monofocal lens. We are going to see some article telling us that monofocal could achieve some amount of depth of field, of course, if the patient have a small pupil, have his inverse astigmatism, could achieve some amount of pseudo-accommodative effect. If we achieve for this cutoff point at 0.2, less than 1.58 dioptries, we are going to talk about the partial range of field is enhanced. This is a group of monofocal enhanced. And we achieve less than 2.3, we are going to have the subgroup of partial range of field extended. Is the EDOF lens that you used to have in the market. What about the full range of field? All the subfamily achieve more than 2.3 for the cutoff of 0.2 logMAR. The difference, what is? It's a decrease in between intermediate and near vision. It is monotonous, continuous, almost no difference, less than 0.05 logMAR. It would be two lines, so two letters, one line. We are going to talk about full range of field, continuous. If we are going to talk about the full range of field is smooth, it's because in between intermediate and near is not too much difference. Less than 0.14 logMAR is less than 1 line and a half. And talk about the full range of field SIP is too much different in between the intermediate and near, more than 0.14 logMAR, more than 1.5 line. What type of lenses? That's right, bifocal lenses. We have here the abbreviature of the ESCRS abbreviature and the graphic solution. It's very interesting. You have here the optical technology that sometimes the companies could tell you, the standard terms based on the ISO, the IC, the regulator, the functional classification that we propose you, and the ESCRS short name that we also propose only to memorize. Why not to include photophenomena and this photopsia in this classification? We tried. We tried, but it's impossible because we don't have a standardized method to collect and report honest scientific articles. So the magnitude of the variability is so much larger than the effect size. So right now, it's not possible. Let's see in the future. We developed for you this application in the Apple Store. It's the IOL evidence. You have the QR code you can download from the Apple Store. You have an iPhone, an iPad, and Mac. And you have all the paper published. Each week we review the PubMed and we include each paper that is new for you. We synthesize the evidence of the paper and we also put a rank, a critical appraisal number, depending of the level of the evidence of this paper. So also we are going to give you a glossary about all the intraocular lenses in the market. According to all this group, we publish with almost any information of the optical band when each launch, but we introduce the evidence according to Congress, journal, and magazine, and we give you the level of certainty. So in a scale of 6 level, of course, I know that is subjective, but it's the most objective possible. It's based on the grade scale. But the lens could vary in the functional classification according to the new evidence. So let's see the market. Let's take a look to the market. Let's see a look to the enhanced. On the top, you have the cutoff point, and you have all the lenses that we have right now, at least in Europe, with by manufacturer, the mechanism of action, model material, and the certainty that we have based in evidence. The more paper, the more certainty. The better paper, the more certainty. In the extended, you have here all in the market, and according to Medicontur, we have the Elon lens, is based in wavefront linking, mechanism, a material hydrophobic, and we have high certainty. We have a paper, the last paper published in review. According to the group of continuous, we have all in the market, and in the smooth transition, we have my intraocular lens. I used to implant in my patient, the Liberty, because of the thing that you had heard in the first presentation, and we have a very high level of evidence. We know the red lines. It's very important to know the red line, when not to implant. It's not anything, but for me, the most important of this lens is we are going to have the deep of field of a trifocal lens, of a smooth transition, full range of field, but the photophenomenon of a EDOF refractive, partial range of field extended. And finally, we have the tip transition. It will be the bifocal of the market. So finally, in conclusion, we have 1 minute. I have a joke to come in this minute. The development of evidence-based functional classification allows us to group in the intraocular lens model according to the outcomes. The key of the functional classification is the efficacy of the lenses. So, based on monocular distance correct distance vision, the focus curve, and according to the certain tune, some lenses could jump from one classification to another. And that's all. Thank you very much for your attention.
Thanks, Joaquin. And I encourage you to look at the recent publication in JCRS on the classification system. I think it's really a very good start. One question for you. The classification doesn't yet include dysphotopsia profile. Is that something that perhaps you want to maybe consider in the future? Because it's always an important consideration for these range of vision lenses.
Absolutely, important question. Yes, this is the beginning of the roadmap. We need to have, as I speak, less marketing messages, more evidence published. This is the beginning, talking a deeper field, but of course we would like to have also the contrast sensitivity, at least for far, and we also would like to have the dysphotopsia, or why not the photophenomenon, but at least the dysphotopsia. We have an incredible questionnaire made by the American Academy, the IOLs, and we are trying to collaborate with the ESCRS, with the ESCRS, with the idea of improve the standardization of all the reporting data.
Awesome, thank you. Okay, we're going to move forward. We're going to move talking a little bit about the partial range of field lenses as well. And for that, I have Sathish, who's going to join us here, Srinivasan from University Hospital in Scotland. He's a professor. He's also associate editor at JCRS, our journal. So thank you so much for sharing your insight into the partial range of field lenses, the ELON lens. Thank you.
Thank you, Ike. Good afternoon, everybody. Thanks for spending your lunchtime with us. Quite excited to see a lot of people here for this symposium. So my remit is to talk about the next product, which is the extended depth of focus lens from the optical standpoint of view, and I'll be spending the next few minutes talking about the ELON, which is the extended depth of focus. As you know, when you look at the paradigm of treating surgical options for presbyopia, we have the standard monofocal lenses, which we have all of us are familiar with. And then when the technology moved, we started going into a bifocal technology where we purely corrected distance and near vision. And then as all our lifestyles changed, we all began to realize that the intermediate vision is very important, then became the birth of the trifocal lenses. And one of the downside of the trifocal lenses was the quantity of dysphotopsia and the patient's symptoms they were experiencing. So there was a birth of new technology, which is called the EDOF, EDF, or EDOF, which stands for the extended depth of focus lenses, which is purely based on the optical principle, whereas Dr. Fernández talked about the functional classification. If you purely look at the optical classification, extended depth of focus lenses are somewhere between your bifocal and your trifocal. They give you good distance, good intermediate, and some kind of functional near vision with the premise that it's going to reduce the amount of dysphotopsias and improve the patient's comfort. So I'm going to be talking about, and there are different optical ways of achieving this extended depth of focus technology. There are so many options available in the market. All of them are not the same. So if you're going to look at the EDOF lenses, it's very important you look at the optical characteristics and the optical principles on which this technology is achieved. Otherwise, you will not be comparing apples to apples. So here we are talking about the extended depth of focus lens from Medicontur, which is called the ELON, which is a non-diffractive technology using wavefront linking. So we'll talk about this. Even though the lens looks like it has got diffractive rings, let me make it abundantly clear, these are not diffractive rings. If you look at a blow-up picture, that is the optic of the lens on the top. What you see at the bottom is basically the lens has got a base curve and it has got two refractive zones. So what you're actually seeing is the two refractive zones. Then we have got a linking zone which links those two zones. And this illustration, this is a Zmax map on an optical bench which purely shows that the base radius of the lens with two refractive zones. If there are just two refractive zones, it almost acts like a traditional old multifocal lens, giving you distance and near. But putting that wavefront linking technology, we are going to link those two refractive zones, thereby creating a continuous path of optical performance. So the top is the one without the linking zone, and as you see at the bottom, once you put those linking zones, you almost get one uninterrupted optical bench, which gives you that elongation of the optical line, and that gives you a good uncorrected distance, intermediate, and some kind of functional near vision. So this is the lens, which is the standard now. It's a single-piece hydrophobic lens, 6 millimeter optic, 13 millimeters in overall diameter. And for people who are familiar with the Medicontur platform, as you can see, it has got the biflex haptic, which means it gives you excellent rotational stability. And as we have alluded before, if you're looking at the optics of any lenses, you need to carefully look at the refractive index. Higher the refractive index, you get glistening. So the refractive index is very important. Lower the refractive index, better is the optical performance of that acrylic material. And similarly, higher the Abbey number, you've got less chromatic aberrations. So if you're going to change technology, these are the scientific optical principles you want to look at to see if a lens is a good lens or not. And this lens, as I showed you, it's got all the good characteristics. It has got a 360-degree square edge, so the chances of PCO are much less. And this is the toric version of it, which is currently going up to roughly 6 diopters of toricity correction. And the lens is preloaded. If you want to play with it, you could go to the booth. It's a preloaded lens, and it's got a very unique characteristics. You can play with it in the booth, and it has got a very nice, smooth injector system, as you would expect from any preloaded technology. Could we move to the next slide? Okay, great. So I'm going to share, I've done over 100 eyes now. These are not randomized studies. These are patients who walk into my practice, or these are real world data which I'm sharing with. So on your top left is the monocular visual acuities at 3 months, and at your bottom left is the monocular visual acuity at 12 months. And once again, this is the standard way of expressing vision scientifically. UDVA stands for uncorrected distance visual acuity, uncorrected intermediate visual acuity, which is standardly measured as 66 centimeters, and then you've got uncorrected near visual acuities. So that's the monocular data for 3 months and 12 months. And if you want to look on your right-hand side, these are binocular data at 3 months and 12 months. And I just want to draw your attention, look at the bar which shows the uncorrected intermediate visual acuity. This clearly demonstrates how that cortical summation works. If these patients with any of these presbyopia correcting technologies, if you implant the same lenses binocularly over a period of time, the cortical occipital cortex helps to summate these optical properties, and invariably you see this consistently. Uncorrected intermediate visual acuity for patients with binocular implantation of the same technology works better compared to monocular implantation of these patients. And this is very consistent. You see this pattern both with EDOF lenses as well as with the trifocal lenses. And this is the postoperative refraction data, once again shown in logmar. The one on your left is 3 months data, and one on your left, on your right is 12 months data, once again showing very tight spread and very good spherical and ciliatrial correction. My cohort contains both the standard ELON and the ELON toric as well, and my next speaker will show more data on the ELON toric. And this is the defocus curve. So once again, the one on the blue is the monocular defocus curve, and the defocus range is shown at the bottom, and the binocular defocus curve is shown on the red at the top. Once again, you can see with binocular cortical summation, these patients have better vision, not only for distance, but also for intermediate with this EDOF lenses. And once again, as the correct way of measuring uncorrected intermediate visual acuity at the standard is at 67 centimeters. That's what you've measured. Once again, that corresponds to almost 1.5 diopter of myopic correction and unaided good intermediate vision, which you get roughly about 66 to 70 centimeters. And this is the defocus curve, once again, with contrast, showing there is no very little degradation of the contrast with this EDOF lenses. So to conclude, the ELON is a type of EDOF lens which is purely based on the optical classification. Once again, there are different ways of achieving this EDOF. ELON lenses uses the wavefront linking technology, which I hope I've illustrated to you clearly. And the data so far shows that provides very good uncorrected distance in intermediate, and these patients do get a bump if you implant these lenses binocularly. Always uncorrected intermediate vision is better with binocular implantation rather than monocular implantation. And they get, even though the intention of the EDOF lenses is not to provide uncorrected near, what we found is patients who have bilateral implantation of the EDOF, still you get about J8 or J10, which is kind of a functional near vision, which is also quite nice to know. And I didn't have data to show all these patients. We do VFQ-25 questionnaire, which is looking at patient-reported outcomes, and the amount of dysphotopsias and dissatisfactions with this technology is very, very less. Thank you very much.
Thanks, I want to remind everybody, of course, to use the QR code to ask questions. There's a few coming in, so we'll hopefully get that. We're going to continue the discussion about EDOF lenses and the ELON lens, specifically talking about toric lenses, and it's my pleasure to introduce Alison Chiu from Australia. She is practicing a wide range of laser and IOL refractive options. She's had a lot of experience with different technologies and teaches a lot. She's also a real firecracker, so we're looking forward to hearing and sharing her ideas. And again, keep the questions coming. A lot of things to talk about with these technologies. Thank you, Alison.
Thank you, Art. I'd like to share with you the results of a pilot study of the Toric EDOF ELON IOL. We're getting closer and closer to the holy grail of presbyopia correction, and we really need to start to meet the expectations and demands of a new patient population coming through. And the world really is changing. So 30 years ago, this is what 50-year-olds look like. And this is what 50-year-olds look like now, as well as this. And moreover, this is what baby boomers are doing in their retirement. So people are leading much more active lifestyles, and we really need to level up to provide solutions for them to give them visual freedom. So the investigational setup was, I'd like to acknowledge Professor Srinivasan. Sathish has given a great presentation on his ELON data, and we've pulled our toric data specifically. So we have 2 centres for this study with a total of 39 eyes. And I'm presenting our initial results of 3 months, and this data collection is ongoing to 12 months and includes refraction, visual acuity, so monocular, binocular, distance, intermediate and near, uncorrected and distance corrected, defocus curve testing for VA and contrast sensitivity monocularly and binocularly, and visual function and patient satisfaction questionnaires, as well as a study of toric IOL stability. Sathish has done a fantastic job of presenting the features of the ELON. All I would like to add here is to aim for plano or the first minus. In these EDOF lenses, if you aim for the first plus, you'll get fantastic distance vision, but you're using up that extended range of focus, and you'll have suboptimal intermediate vision. The implanted IOL powers were across a range from 15 to 27, with, as expected, most of them concentrated in the middle, and the IOL cylinder powers, as expected, were concentrated mostly at the lower end of cylindrical correction. The outcome results at 3 months showed that 100% of eyes fell within plus or minus 0.5 diopters. And I just wanted to take a moment here to talk about how we might be targeting our results. So in Australia, what I tend to do, we have the Barrett formula, as you do as well, but Graham Barrett's close to our heart. I use the Barrett K formula to select the sphere, so that's a predicted total corneal astigmatism method. And to select the cylinder power and axis, I use the Barrett TK, so a measured corneal astigmatism method. And we get good results with this. So in terms of the monocular visual acuity results for far distance, and as Sathish alluded to or mentioned, the results would be far better improved with the binocular summation, but these are the monocular results. We see that 87% of distance-corrected eyes are seeing 20/20 or better, and this is a real-life study, and 96% are seeing 20/25 or better, and all eyes are seeing better than 20/32 or better. For the binocular intermediate and near vision results, I've measured these in N form, and we see that 81% at intermediate are seeing N10 or better, and 100% are seeing N12 or better. For the near visual acuity, we see that 81% see N10 better, 94% see N12 or better. And this is better than expected of what we would have the expectations of an extended depth of focus lens. The defocus curve speaks for itself, and it really is a true partial range of focus, extended depth of focus, IOL. So this is the monocular results again. For the astigmatic correction, we find that 87% of eyes fall within plus or minus 0.5 diopters of residual CIL, and 100% of eyes fall within plus or minus 1 diopter of residual CIL. So in terms of astigmatism correction, I also want to turn to some tips. Do not be afraid to flip the cylinder. So unlike in glasses and contact lenses, there's no prismatic effect in IOLs. So we implant the IOL that leaves the least amount of residual astigmatism. In Australia in particular, we love our toric lenses, and most surgeons use somewhere in the order of 60 to 90% of toric lenses in their practice. Fully correcting astigmatism is very important for the best performance of an IOL, and we know that EDOFs are more forgiving. And Dr. Fernández alluded, and Lupita alluded to the premium, such as multifocal IOLs, this being crucial in providing great visual outcomes for patients. In terms of the patient-reported outcome measures, the majority of patients can perform their usual activities without or with only minor difficulties. 92% of patients are completely or very satisfied with their vision, and 92% never require spectacles for far and intermediate distance activities. This was a small study of 39 eyes, so we had 1 or 2 outliers producing these results. In addition, 54% of patients were completely or very satisfied with their near vision without glasses, and again, this is despite near vision not being an expectation of EDOF IOLs. So the take-home messages. The Elon EDOF IOL from Medicontur provides excellent results for distance, intermediate and near, noting that this is not an expectation. And I will tell my patients to expect reading glasses, but it's pleasing to see when they don't. It has a wide defocus range with sharp vision, regardless of range of vision, and a high level of patient satisfaction with a low level of visual disturbances. And these are uncommonly experienced and not bothersome. And I noticed that half the room aren't using presbyopia correcting lenses, so I think that this would be a great place to start. I recommend to leave the least residual astigmatism, and this involves flipping the cylinder if needed, and also to consider for your practice using Barrett K for sphere and Barrett TK for CIL power and axis. We also found that the vision settles significantly between 1 and 3 months. So although it's common practice at 1 month to deal with residual refractive error, so for example glasses or something further, let the VA settle for 3 months before you make this decision with your patient. Thank you.
Thank you very much. We're going to take some time for some questions in a second, but I just wanted to say that, we have so many, and thank you, Joaquín. Joaquín has to leave, so we appreciate you being here. And speaking of Joaquín, one of the things that, I noticed in the panel is that we have a very credible group of speakers. It's always hard to differentiate the marketing and the evidence here, but there's a real attempt to speak to the evidence, which is important. And before we get to Johann coming, I have a seat. I just want to get a couple of questions here. And one of the things I also noticed as I kind of did my diligence here, that when I speak to surgeons who use technology, you can kind of get an idea how devoted they are to the technology, and you kind of speak to people using lenses, and some people say, yeah, I do this, I do that. Others will actually speak to how much they really believe in the technology, and that's something I've noticed with these options we have here today. A question for the group here. You know, we've talked about the full range of vision and extended range of vision lenses, and how do you differentiate the technologies with a given patient in front of you, with the two options we talked about today? Lupita, what do you think? I mean, we have these EDOF lenses, we have full range of vision lenses. How do you kind of decide where to use what?
The real truth is that in Mexico we haven't arrived alone, so I don't have a great experience with alone, but maybe.
So Alison, what about yourself? You have experience with both technologies?
I start with a lifestyle questionnaire, so I ask the patient what they're wanting to achieve, and with that, I go from there. Then I'm also looking at the suitability parameters like angle alpha, pupil size, and if they're not optimal candidates for a trifocal, so for a Liberty, then I'll defer to an extended depth of focus, and I also use that quite a lot in a mini monovision configuration, and so I'm probably using, that's probably becoming more and more of my practice.
Great, thank you. And I usually start with the full range of vision lens and start with that and then move down if need be, depending on the patient's interest and comorbidities. Okay, we have Johann Kruger, who is from South Africa, Cape Town. He is a wide-ranging member of so many societies and has a lot of experience with different technologies here. He has some interesting thoughts about how to, you know, use both technologies to achieve perhaps the complete outcome. So thank you, Johann, for being here.
Thank you for the invitation to talk here. It's a real pleasure. So I'm going to speak about a concept called custom match. It's blending the strengths of the trifocal and the EDOF lenses for optimizing your surgical outcome. So there's a high demand for spectacle independence, as we well know, due to active lifestyle, baby boomers. I brought my surfboard, by the way. Digital era, technological advancements, and COVID. And we also know that, and we saw with Joaquín's lecture, there are many lenses, and there's lots of confusion. You know, it's almost like being on Tinder, where you have to swipe yes or no. So patients don't really understand if you speak to them about an EDOF or a trifocal. So you've got to use the concepts of full range of vision or partial range of vision, and the patients really understand that much better. So now that we've learned about Liberty and Elon, can we combine them? So the main aim would, of course, be to have a full range of vision for the patient, less glare and halo, and be able to be versatile, reading a small document here, reading your phone, reading your desktops. So if you want to match the IOL to the patient, you need to do a very complex assessment of the patient, long chair time, special pre-op investigations, very good surgical planning, and look at patient-specific ocular characteristics. This is key. So the corneal astigmatism, health of the ocular surface, angle alpha is very important. Pupil size, of course, whether the patient had previous LASIK, higher order aberrations, how many are there, and other ocular comorbidities. That's the key in deciding, and understand your technology of your lenses, your optics. And then, of course, as Alison also alluded, is we have to understand the patient's considerations, such as their lifestyle, their hobbies, their goal, visual goals, profession, etc. These are key elements, and this holistic approach actually helps us make a proper informed decision on which IOLs to use. So we look at the quality of the vision. We have to look at the cornea, and we have to look at whether there's decentration, particularly in post-LASIK patients, positive and negative aberrations. And, of course, the angle alpha. The one on the left is not very suitable for a trifocal implantation, but the right is more suitable. So here are my results in combining these two lenses. What I did is here's 41 patients that I implanted the non-diffractive Elon lens in the dominant eye and in the non-dominant eye, the Liberty lens, which is also, these lenses are also, as you probably saw in Joaquín's lecture, are zero, they have zero asphericity. So this is we found very excellent range of vision in the patients with, as you can see there, we measured the Elon separately, monocularly the Elon and monocularly the Liberty with really great results at 0.02 at year 1 and 0.06 at year 1 with the Liberty. But with binocular at 60 centimeters, it was 0.09. So that was much better. And also the binocular near at 1 year was also 0.09 with the combination of the lenses. Then if we look at the intermediate binocular at 2 to 4 months and at 1 year, you see that there's an improvement. And also with the near binocular, we've found very good results of 100% 20/30 vision. And also at 1 year, it was very good. And if we look at the bifocus curves, we see it's almost a straight line. And you can, if you look at the blue line, which is the 1 year line, you can see there's an improvement in vision at 1 year. And this I attribute to neural adaptation. There's certainly a summation of vision, as we also saw in Sathish's lecture. And you can go and use your eye trace, and you can measure this, and you can see how the vision is, the bifocus curves looks. And what I've also done, I'm probably one of the few in the world that has actually used the custom match approach with the toric lenses as well. And here I also had a patient that I achieved uncorrected distance vision of 20/20 and uncorrected intermediate at 60 centimeters of 20/25 and uncorrected vision at near 40 centimeters 20/20, combining the toric Elon lens and the toric Liberty lens. Looking at the patient satisfaction, we also do a questionnaire. We do a lifestyle questionnaire as well before we implant these lenses, and we saw that there were a number of patients, about more or less 30%, that did experience glare halos, but didn't have really big difficulty with it. All the other functions we tested were really minimal difficulties with. And then also now, let's just look at where not to use this custom match approach. Of course, when the cornea is not suitable, the higher order aberrations more than 0.3, severe dry eyes, retinal pathology, people that are actually doing very little near work, why would you put a trifocal in for those patients? Contraindications for trifocals, it would be the same here. Sensitivity to halos, angle kappa or angle alpha actually higher than 500 microns. More of an issue really in the post-LASIK patients. And by having said that, I use this approach in LASIK patients because these lenses are zero asphericity. People smaller than 3.5, so between 2.5 and 3.5 you can use it, maybe less than 4. And then where to use it? When patients want good distance vision in both eyes, they actually want a full range of vision, and they understand they will experience some halos and glare, and do easy work, read fine print, accountants and lawyers, and post-LASIK patients because it's a neutral aspheric lens. And I found less glare and halos in these patients. I think there's a quicker neuroadaptation in these patients. If you're only having a halo in the one eye and not in the other eye, and if you put the EDOF lens in the dominant eye, you will have less halo effect because the non-dominant eye gets ignored much quicker by the brain. Thank you for your attention.
Thank you very much. We're going to just move forward. We just have one more talk from Brian Harrisburg. Now, I want to tell you my first experience with Medicontur was doing live surgery using what I think is a very cool idea, using an add-on lens in the sulcus for a patient who's already pseudophakic who wanted to achieve multifocality. And it was actually during live surgery. It's very cool. I really enjoyed it. And Brian, who hails from Sydney, Australia, is going to give us some tidbits and information about the add-on lens. Thank you very much.
Thank you, everyone. So this is a sulcus-based lens, and it's your get out of jail card. It's to manipulate the refraction so that you can achieve best outcomes. I'm going to give you some examples. So first of all, it's a lens that is planar. It's got a convex concave shape, so you avoid iris and you avoid the underlying pseudophakic lens. It differs to all the others on the market because it is a square lens with 4 haptics designed for minimal ciliary sulcus touch and great torsional stability. And this is the major difference between all the other C-loop designs on the market. So I've used them in all these examples. And you can get this custom made. It can be a power of sphere, sphere and cylinder, pure multifocal, multifocal toric, and you can also have it as a magnifying system. So there are many, many opportunities to use this lens. And I think everyone who does cataract surgery, this is a lens for you when you know how to use it appropriately. So what are the keys? It's versatile. You can change power if there's refractive error and you don't have access to a laser. Add or subtract whatever astigmatism you're working with, create multifocality and magnification. It's adjustable. Those corneas that have unreliable data, such as post-graft or keratoconus, pellucid marginal disease, and you're not quite sure that you're matching all your diagnostics in terms of power and axis, you can put this lens in the sulcus and have an opportunity for either removing and adjusting or just rotating. It's very easily reversible, and this is a good choice for the confused patient who doesn't want to lose the opportunity of a multifocal option. And we say, okay, we'll put the multifocal outside the bag, and if you don't like it, we can remove it. So this is practical tips. These lenses are big and they belong in the sulcus, but you can't just shove them in. So in the anatomical requirements, we need reasonable pupil size. You have to have adequate zonule support, anterior chamber depth requirements, and measurable corneal astigmatism if it's a toric. So the loading technique, you have to be aware there are 4 haptics. Each one must be tucked appropriately. When you put the plunger in, and usually it's with backfilling of viscoelastic, you push the plunger forward and retract to make sure it doesn't capture these delicate haptics, and you slowly inject. You inject aiming at the iris plane. It's a bit like ICLs. You do not try and aim it into the sulcus because you'll have a steep descent and you could dislocate the in-the-bag lens. Expect a big lens. It's very big, but it's manipulatable. Implant slowly. And also, this is key. Position 1 haptic at a time. Don't be the hero. Rotate, position forward, and horizontal rocking is really important because the haptics can fold underneath the iris and you can't see it. That will create tilt and decentration. So you've got to get it in the sulcus, but let each haptic unfold. Check the toric position of the underlying primary IOL in case you move it, and thoroughly remove viscoelastic behind the lens. Do not leave any viscoelastic, you'll get a high pressure spike. Problems also, if it's a small pupil, you'll have to deal with that because you have to allow access. And post-op, if it's a big pupil, you have to take the patient to the slit lamp in the OR or in the recovery and check that each haptic is underneath the iris. No peripheral iridotomies are required. So a quick case study, if I've got time. This is a lady who had primary cataract surgery in 2003. They weren't using torics as much, and there was no toric lens put in. She had ongoing astigmatism and decided she wanted glasses independence, and the surgeon put in a sulcoflex lens, which managed to rotate, and it rotated twice even with repositioning, and that's when this patient was sent to me. So the plan was, okay, the sulcoflex is moving, the add-on won't, I will swap them out, and the calculation was based on the sulcoflex back vertex distance measurements. So I just copied and pasted what the sulcoflex was, and we did an IOL exchange. So here's a simmering ring cataract with a primary IOL and a sulcoflex lens. This comes out very easily as one piece through about a 2.65 millimeter wound. And once this is out, now I can get my add-on in. I didn't touch the simmering ring cataract because I didn't want to change any positioning of the primary lens. So I positioned the viscoelastic discreetly. You don't overfill, just aim for your 4 positions. Here I'm tucking and backfilling and injecting slowly, aiming at the iris plane, slow unfold above or at the sulcus, but not downward pressure. And then there's a forward rotation. So you deal with the haptics in front of you. You don't try and get it behind. It's not necessary. So what happened to this lady? She got good unaided distance vision on day 1, and the lens never moved. 1 year later, it's exactly where we want it. There's no residual astigmatism. Then I'd like to introduce to you this concept of dual lens study. We looked at data for 2 arms, a 1-year study, the Liberty and Liberty Toric in the bag versus monofocals in the bag, but the add-on outside. Why? Perhaps you want to reverse this. There are some patients who can't come to terms with making a decision, and you may have data that is a bit iffy and you're not sure whether this patient will tolerate the lens, so I'll offer this option. And here we go as easily reversible trifocality, and we compared these 2 lenses. The data was exact. I couldn't believe how similar the 2 lenses are. Just remember the add-on's got 6 rings and the Liberty's got 7, but across the distance visual acuity and near visual acuity, it was the same outcome. To be honest, I think the add-on is even better centered on the pupil. And if you look at the refractive outcome, that's based on good data in, good data out, spherical equivalent within 0.5 in 98% of cases. And we never had a pressure spike long term. At 1 year, all the pressures were normal. So what's the 5-year experience? No iris transillumination defects, no rotational issues, no IOL opacification, no explantations. Even in that subgroup who said, I'm not sure I'm going to handle multifocals, there's a similar PCO rates. You need a long-term commitment to looking after these patients because of ongoing or progressive zonulopathy or dead bag syndrome. Thank you very much.
Thank you. We're going to just hang on just for a few minutes. I did want to mention a very important announcement, so I need your attention. Tomorrow at 10:30 in the morning, there's a very important event. Okay? Wow, everyone's quiet now. Alison and me are going to be presenting at the Medicontur booth on the add-on lens. So you have to be there. I want to see everybody there, okay? There's big prizes. So look forward to that. Okay, Laszlo? So I just wanted to there's a couple questions from the audience here. A question about pupils. Do you measure pupil size? How do you use it with selecting lens technology? And what technology do you use? Lupita?
Well, we can use it with the pupillometer. That's one of the measures. And then the OPD. If you have an OPD, it will give you exactly the measurement of, and we do it with light and without light.
Okay.
Otherwise, you don't know how it's going to be the patient during the day.
And Alison, I mean, how do you use pupil size to select lenses? Is there certain pupil size that you choose one lens or the other? I mean, how does it make a difference in your choices? Or
Well, to tell you the truth, after Joaquín made the study, I'm really concentrated on the size of the pupil. So if I have a 2.5 or 3 millimeters, I can put either of the lens. But if it's bigger, I just try to a monofocal one.
Okay. All right. Brian, question for you. When do you decide to use a multifocal add-on lens?
Can you hear me?
Yeah.
So the multifocal add-on is when you got to do a detailed consenting, informed consent. These patients have an inability to decide, and it's our duty as doctors to say, these are all the lenses out there, these are all the platforms, but this one is a reversible option. So it's for that patient who's not sure.
Okay. Johann, you talked about a very interesting custom match approach. Does it matter which eye is a dominant using lens versus the non-dominant eye?
I know that's controversial. I believe that the non-dominant eye should have the trifocal because of neuroadaptation. That's what I think. And also if you undercorrect the patient in any way in his dominant eye, he's going to be unhappy, even if it's LASIK. So I like to have a distant dominant lens in the dominant eye and then more a near dominant lens in the non-dominant eye. And I know there are surgeons that differ from me from that, but it's working, and I'm using this technology. I've used it with other technologies as well in the past. I started in the 90s with this mixing and matching, which was an American concept, but I always stuck to it's a customized thing. You're customizing your approach. So I'm proposing rather a custom match concept.
Alison, what about using extended depth of focus lenses like the Elon lenses in patients who have comorbidities, like, for example, corneal pathology or glaucoma or macular pathology? What is your thoughts on those patients?
The EDOFs definitely are more forgiving than a multifocal lens. I think you have to apply the same principles, but you have a little bit of leeway with the extended depth of focus lens with the Elon. So with very mild macular pathology, with very mild glaucoma, and with mild ocular surface disease, mild to moderate, it's tolerable, but intolerable with a multifocal.
Okay. Sathish, you have a young patient who's a monocular cataract. Would you consider presbyopic lens technology, and which one would you think about?
That's a great question. Once again, depends on the patient's lifestyle. I would probably tend to lean away from a diffractive trifocal technology if it's just a monocular implantation.
Johann, you had a comment?
Yes, I think in any young patient, you can even unilaterally implant a trifocal lens. The young patients are used to seeing up close and close, middle, and near. So you need to give them a full range vision lens, a young patient. Otherwise, they're losing something.
Controversial. Good. I like some controversy here. Okay, Lupita.
What I like now of all the technology we have, we can start with a monofocal, and maybe in the same surgery or weeks later or years later, you can do an add-on. So you give trifocal.
Yeah, that's a really interesting.
When the monofocal is stable and everything is fine.
Yeah, that's a good way to. Maybe Brian was going to say that as well.
I could live with that.
Sathish, I'm like, good. We're compromising. We're agreeing here. Consensus.
I'm going with Johann. When you get that young patient, if you take something away from them, they're not going to be happy. So go full multifocal, even if it's monocular.
Well, I mean, I still don't wear any glasses. I'm not that presbyopic, but I definitely don't want to wear glasses after. So, Alison?
You can ask the whole panel and we'll all have different opinions, but it's individualized. It depends on the patient's lifestyle, their ocular parameters, about what would fit. But if they're suitable for a multifocal, I think an add-on is a perfect opportunity.
I think it's a very cool idea. Yeah, putting it together. Okay, I know we have to go through a quick question. Where do you aim? What is your refractive target for Elon and Liberty lenses? Is it different, the same? What's your quick answer on what do you aim for on the biometry printout, right? Oh, sorry.
Liberty, you have to nail the astigmatism. You need to put in under 1 diopter of astigmatism. You got to correct that. Don't leave any refractive error unturned with a Liberty.
Alison, what do you aim for your lenses?
Liberty Plano First Plus, Elon Plano First Minus.
Does anybody use EDOF lenses like Elon and aim the non-dominant eye a little bit myopic to give them a little bit perhaps near vision?
Yeah, I'm doing a lot of mini monovision, and I'm seeing the patient after their first eye to see what the near vision's like, because it is a little bit variable, as you could see from the results.
Yeah.
So that allows me to determine what the offset will be.
Satish, what do you aim for typically in a non-dominant eye for the Elon lens?
Plano or the first minus.
Okay, and what about, do you do a bit of mini monovision? No, okay.
I don't, but once again, I mean, there's no harm in doing it, but the key for all of this is to nail the biometry.
Yeah.
If you're going to do mini mono and if you're off target, patient is going to be unhappy.
Yeah. Brian,
I'm actually using the micro monovision approach. So I aim 0 or first plus in the dominant eye, and in the non-dominant eye, I'm aiming minus 0.5 or minus 0.75, and they pretty much have a full range of vision.
Brian, if you have any comment on that, you agree? Okay.
Yeah, so again, dominant eye, plano, and then a little bit of an offset. I don't go big offsets, I don't love monovision, and so I want the lens to do the work, so I'll aim minus 0.3 up to minus 0.5.
Lupita, well, last question. When I polled the audience, we had about maybe a third using multifocals, maybe a little bit more using EDOFs. What are the biggest barriers for surgeons using this technology and getting started on these technologies, and how do you address that?
Well, the first one I would say personality.
You mean your personality or the patient personality?
No, if you have a very demanding patient, you have to be very careful, because those patients are going to be dissatisfied all the time. So as I show in my slides, the first cause of dissatisfaction is bad vision. So if you don't target the vision, the patient is not going to be happy. Second one is the posterior chamber, the posterior capsule opacification and dry eye. And so you have to really take care of all the variables to have a happy patient. Even if he's 20/20, he can be unhappy.
Sure, true. I think there's a bit of a fear. You hear about patients who have dysphotopsia, halos, and glare. So I understand that, and I think that if you haven't started with presbyopic technology, I do think that the EDOF platform, the EDOF lens, is a very safe place to start. The risk of dysphotopsias and halos are virtually almost as a monofocal, and it's a bit more forgiving lens. It's a great place to start. Get comfortable with this, and then you can move toward full range of vision lenses. And there you're going to have to think about more. Liberty, interestingly enough, has some design features that may reduce some of this, but I still say maybe start with EDOF and move forward, and then you'll hear a variety of options that are in front of you. And I think the add-on thing is I think it's very cool. I'm really interested and excited how it opens up opportunities for technologies. Many years ago, people would have thought, oh, there's no way we're going to put multifocal technology in the eye, and here we are. So I'm excited for that. Well, I could talk all day, but I think I'm probably going to get kicked out. I already have enough people who are angry with me at this meeting. So I look forward to more discussion. Again, I would say that this is a really nice, almost family-originated company, Medicontur. You feel like you're with a family. I had some time yesterday spending some time with them and the speakers, and so I encourage you to really get a chance to kind of understand, where we're at. It's not really about selling anything. It's not about marketing, but I think we really just are here to learn and to, do best for ourselves and our patients. So thank you for being here. I hope the lunch was good. I cooked all of them myself. So, I'm not bad, I hope, but thank you very much. Enjoy the day.